is 12:15, so we're going to go ahead and start. I want to thank everyone for participating in this Center for Physician Resources webinar this afternoon. My name is Elizabeth Reese, and I'm with the South Dakota State Medical Association. At this time, I would like to remind everyone that the phone lines are open, so please keep your phones on mute or keep background noise to a minimum during the presentation. Now I'll go over to Stacy, the Communications Manager at the South Dakota Foundation for Medical Care, to introduce our speaker.
Elizabeth, the Foundation for Medical Care is part of the Great Plains Quality Innovation Network, and we're excited to be partnering with the South Dakota State Medical Association to offer a 10-part series of webinar briefs. Key care topics have been presented in 15 to 20-minute webinar segments, highlighting provider and clinician perspectives, while using corresponding resources and tools. Today, patient-centered equals quality will focus on relating patient-centered care with administrative priorities. Any business, patient satisfaction of the health services and resulting outcomes impacts the bottom line. Policy workflows can create efficiencies, but are using the results the patient expects. I'd like to introduce our speaker, Todd Jacobs. Dr. Jacobs is Chief Medical Officer with the Vera Medical Group. He has a degree from the College of Osteopathic Medicine and Surgery in Des Moines, Iowa, and is board certified in family medicine. He's been a physician in South Dakota for 35 years. He is a member of South Dakota State Medical Association, American Medical Association, and the American Osteopathic Association. He's passionate about bringing quality care to rural communities. He and wife Kathy on their farm north of Flandreau, where they enjoy playing with their 6 grandchildren. Thank you, Jacobs, for sharing your knowledge and expertise with us today. Go ahead and begin your presentation.
Yeah, Stacy, and I would add the most important part of that whole deal is those 6 grandchildren. I'd lift that up. It's all joy to have them on the farm. Good afternoon, everyone, and thank you for taking time to join us today. And I want to start by thanking both Great Plains Network and SDSMA for putting on this series. I think this is it's a wonderful to share information as we're all kind of are trying to find our ways through this new world of healthcare, and certainly lots of changes, and there's nothing better than actually sharing ideas. And so that's part of what my goal is today, is just share with you some of the things that we hear at Avera. Background is primarily in family practice, and I practiced in Flandreau for those many years, and I think I continue to see patients, although once a month I do. Del Rapids reminds me every time I'm there just the fast pace that we're in that clinic environment, right? And so it's very easy to, you're just trying to get through your day, and I can remember as a clinician, days when you finish the end of the day and you ask yourself, did really spend the time that I should have with some of those folks and some of those patients. That patient really understand what I said to them and so forth. And so I understand that environment, and so trying to identify ways and new models in which we can engage patients, I think is really important. And our coordinated care model is one of those. We're going to give you a little more detail about that today, and at any time I'm happy to answer questions, but we're going to try to allow some time at the end of the half hour for you to ask some questions as well. Well, let's just take a look at the objectives for this session. I do want to review kind of the value of coordinating patient care. Patient-centered medical homes have been around for a long time. Our model of coordinated care follows that patient-centered medical home model. We're going to review what that looks like with you. We're going to share what our footprint looks like and how we've grown that footprint. We want to look at outcomes, because ultimately the question is, are we making a difference with what we're doing? And so I review some of those outcomes both on the national stage for PCMH and then also some of our own local outcomes. And part of this then becomes, what about patient satisfaction with what we're doing, and are we really moving the bar there? And so I want to share with you just a slides on some of the work that we're doing in the area of patient satisfaction, and explain a little bit about that program, and I'll show you some of those results as well. Well, there's a question that in our world of healthcare, silos get created, and sometimes communication and coordination between those silos is poor. And so I think we all, there's hardly a talk you hear anymore that doesn't talk about the importance of coordinating our information between those entities. And you know that siloing of care is estimated to cost anywhere from $25 billion to $45 billion dollars annually, and so that's kind of prompted a lot of changes in healthcare that are causing the shift that we all know so very well. You know, this slide is starting to look pretty old because, you know, there was a time when we created this that we really were preparing for the payment shift, and you know that the payment shift is already here, right? So the CMS was projecting alternative payment models of 30% by the end of 2016, 50% by the end of 2018. WERA felt like we really needed to get our toe in the water, so to speak, to understand some of those alternative payment models. And so starting back in 2015, we applied for and became part of the national rural ACOs that are a model in which there's no downside risk, it's all upside risk. So we thought it was a good way to be able to learn about ACOs. Well, we just got information back from our data in 2016, and we have created two ACOs with of about 10,000 lives in each ACO, and there was about 5 or 6 clinics in each one of those ACOs. And we were fortunate, one of them in 2016, to really have enough savings. You have to save more than 3% to actually share those savings with CMS, and so we're able to actually do that with one of our ACOs. And part of the learning from that adventure really has been the importance of coordinated care, of really identifying those patients, those populations that really need our attention, and developing a format that would allow us to engage those patients in a deeper way. And that's what coordinated care really is all about. So let's look at just that traditional setting, right? Patient has that appointment that's 10 to 15 minutes. The nurse room's the patient. Physician enters the room, does the evaluation, completes the exam, maybe talks to the patient a bit, the patient leaves, and then what happens? Very often, the patient returns home. Maybe they're elderly and they're not sure, and the family is asking them, well, what did they say? And the patient, is asking them, so what was I supposed to do? What was I have? Did I have lab work? What was I supposed to do with this medicine and so forth? So that really is probably the more typical stage that I think is out there, and I think can all relate to that. Again, I've had those days where certainly I felt that I wish I could spend more time with patients than I did. The question is there a better way to do that? And we started our efforts with our coordinated care program a little over 5 years ago, and we looked at the fact that there was a lot of duplication of services, fragmentation of services. We felt like we could do more to increase patient satisfaction, patient safety, patient quality. We also were hoping we could find something that could reduce provider burnout. That's obviously a big issue in all of our environments, and so trying to impact that was also one of the reasons that we wanted to do that. And part of part of the message that I gave to providers as we reached out to talk to them about the program was, look, our goal. Well, what I said to them was, there's nothing worse than somebody from administration coming down and saying, hey, I've got this new program for you, because that really usually means I'm just adding more to your plate. And message with coordinated care was, really what we're trying to do is provide you surround you with additional resources and services and folks that can help to take things off your plate and actually reduce your workload. So that was part of the goal of our coordinated care model, and I think that we have been very successful at getting there. What does that look like? And this slide has become a little bit dated, but obviously it's patient-centered, right? So patient and family are at the center of that model. Engaging with the clinical team in the clinic setting, so the physician or the advanced practice provider and the nurse that are primarily the unit taking care of the folks. The coordinated care team works very closely with those folks embedded in the clinic, and that's really key. If they're not embedded in the clinic, I think it's a very difficult thing to occur. So they become part of the team, and they then surround the patient with care. In our best case model, then the coordinated care team may reach out to the physician and say, we have identified the patient that we really think is a good candidate for coordinated care, and we have criteria for enrollment of those patients in the program. Now, they have to have so many medications, they have to have so many comorbidities, they have to have maybe 1 or 2 readmissions to the hospital, maybe more than one visit in a year's time. And so the team will approach the physician and say, hey, we think this person is a candidate for coordinated care. We'd like to get them enrolled. If they agree, in the best case scenario, there was a warm handoff from the physician to that team. In other words, they're introducing that team to the patient and saying, these folks are going to help me take care of you, so you may be getting some calls from them. I want you to know that they're an extension of me. They are part of the team here at the clinic. And so that model really has worked very well in terms of getting engagement, not only from the clinical staff in the individual facilities, but then also from patients as well. So the core of the team is an RN case manager or care manager. We try to identify nurses who have been, I want to say, clinic battle tested, understand the workflow in the clinic environment, and that wheel that often we find ourselves running on. So that person really is responsible then for facing directly with the patient, disease management, and then also education of the patient as well. Supporting that RN case manager then is a care specialist. Usually these folks are MAs, and they really are kind of data management folks. They're really the folks that are able to data mine patients that need to be seen, maybe patients that have a disease entity, we'll say diabetes or hypertension, who haven't been seen in recent time, to be able to get those folks in. As we've got more sophisticated, I'll have information that we can deliver to those care specialists to identify. There's something that we call Health Tracker in our system that is basically the schedule for that provider for the day, and so look at by patient what the overdue health maintenance needs are for those individuals. So, for example, if someone has not had a mammogram or a PAP or a PSA or whatever, that information is on the Health Tracker. If it's up to date, there's a green check, and if it's not, there's a red X. You hover over the red X and actually see then when the last episode occurred and what needs to be ordered. So that has been very helpful tool for those care specialists, and then also for the RNs, and then the physician and nurse team be able to identify on that visit day what are the things that we need to order for those. And they do include things like immunization. More recently, we've been looking at their risk opportunities. In other words, if someone has had diabetes and hasn't been seen in a year's time, then we say, hey, that's a high risk. We've got to make sure that we get that individual in. Care specialists can look at that that tool and help support the team to get everything done for the patients when they're in, or get them in the door if they haven't been there. The more important, one of the more important folks that are involved in those teams are the social workers, and we've been successful in at least providing 5 or 6 of our teams with social workers. And the goal is to have every team have a social worker. But those folks really look at those psychosocial needs at the patient, talk about advanced care planning, talk about financial concerns if they have those. And these have become the folks that really are the folks that these people become very close to, can reach out as a support person to when they have questions or help. So that is the basic coordinated care model that we had. We've also added pharmacists, dietitians, those types of folks to help to support the team as well, and we'll talk about that in just a little bit. This is what our current footprint looks like. We have 13 teams, and there's let's see, 1, 2, 3, 4, 5, 6, 7 teams that look like they have a social worker that is present. One team may have a central location, so you can see that some of these teams, if you look around Sioux Falls, are centered in Sioux Falls, but they serve multiple areas. And so these folks will at least weekly be on the road and travel to some of their other sites to be present with that team. We've found without question that the best place for these teams to be is embedded in the clinic environment in a remote location. Where we've had not so great success has been a situation in which they haven't been co-located there. So an important piece for those of you who are considering this kind of model. Well, connecting the patients to the care team that at times can be challenging, and so one of the things that we've piloted with coordinated care is to leverage our basically direct to consumer model of Avera Now, and so what that is the ability for a patient to connect with our care team members by either their smartphone or their desktop. And so this is extremely valuable. Patients want to connect with people. It's a little bit deep way of connecting than just on a phone call. We actually visualize the patient, and those who have grandchildren are used to Skyping with those grandchildren, so you can understand that. But this has been very helpful for us, and we're in the process of actually extending that to pharmacists, dietitians, and so forth, so we can help to connect in the patient's home in an easier way. A little bit about outcomes, and this slide actually comes from the advisory board, but I found it to be very helpful when we're looking at these outcomes. So, in that fee-for-service model, when you have a medical home and a coordinated care model, Certainly, what we've noticed is we've had increase in the amount of testing because you're pulling people in. I talked about the health tracker a little bit ago, making sure those health maintenance items get ordered. So that actually is increasing in some of those testing revenues. We have definitely heard from our providers that these teams help reduce burnout. They do help take stuff off the plate. And so I remember one provider saying, you know, I call our coordinated care team the godsend team because they really are helping me in ways that I couldn't have imagined. So a wonderful thing to hear from them. We're going to some of our quality outcomes, but nationally, patient-centered medical homes had better outcomes for blood pressure control, cholesterol control, for example, and overall diabetes care. There was an increase in generic drug prescribing. Fewer readmissions. When you look at that shared savings or that capitated contract, which we're looking at much more closely we had before, there's definitely a reduction in readmissions, emergency room visits, for example, and just overall reduction in costs with these models. So you're spending money, right, to put these teams in the long term. It's clear that we're able to save significant amount of dollars. Our outcomes, we have 1,700 patients enrolled in our coordinated care program, but overall we've seen a 54% reduction or improvement in ED utilization. Hospital admissions down 19%. Now, you're a CEO of a hospital, that doesn't make you very happy, but I mean, from our perspective, that's an improvement. Increase in PCP visits, and a significant increase in ancillary visits. Some of those are laboratory, but a lot of those may be referrals to appropriate specialists. And these are relative improvements. Improvements in mammograms, pap smears, colorectal screening, diabetes, the A1Cs, hypertension, and obesity. So these really reflect what's out there in terms of national data. And so it's clear that we're making a difference for these patients that we engage. I'm not going to go into great detail about this slide other than to say that there's lots of programs supported by coordinated care, and so these teams have sometimes gotten stretched from actually trying to take care of patients and then supporting these other programs. But tied to most of these programs are passive dollars. I'm going to call them dollars that will flow back to the system. And so there's lots of applications for utilization of those coordinated care teams. Just a quick example. This goes back a ways, but this is a typical patient, and it's probably more the stories than anything else. You know, I mean, we can show data, but we've had some unbelievably heartwarming stories, engagement by the coordinated care teams, dealing with those people in a deeper level, and then stories that come back to us. But there's a 73-year-old female with multiple comorbidities is listed. Referred to coordinated care by the primary care physician, was on a home health list once we got that program implemented. She's working with coordinated care and assisting with medical needs, while supporting her sister, who was the primary caregiver. They worked with the patient to establish what steps needed to improve her life and living. They helped with some assisted living. With some of the overdue health maintenance items that were needed, and if you look just at the green bar was prior to the engagement, and then the blue bar is the participation in coordinated care. So reduction in the number of appointments made, the appointment kept were better. The PHQ-9 score dropped, and this patient had the kind of outcome that we would all hope to have from these folks. So, really great stories I can share with you if we have time at the end here. But just an overall great program. I'm going to transition just for the next few minutes to that patient satisfaction piece. Obviously, our goal is to make sure that we are improving and making an impact in these patients. We have surveyed our coordinated care patients initially and then afterwards to make sure that we're making a difference in their lives. But then in a greater mode, we're actually looking at what thing we do in our clinic environment, try to make a difference for those patients and engage them in a deeper way. You know, what we view as clinical for performance, how we view ourselves versus the perception of the patient really can be two different things. So that nonverbal communication, if we're really busy at the day and we appeared hurried or not engaged, making eye contact with the patient because we're our head's embedded in the MR, not taking the time to explain a diagnosis, not showing the patient in that decision making, not really explaining natural history of disease. Those are all things that take time, right? And so often these are things that fall through the cracks, and so we often don't do necessarily what as good as we think we should. So when patients trust their provider, we know that they take their medicines better, they follow advice better, they're more likely to get better, and so it just reinforces what we need to be doing these things. Patients be listened to, they want to know that they're cared about, and they assure that they've been receiving expert care. So I think the challenge is, again, our self-perception is usually, yeah, pretty good at that. I'm pretty good at this stuff. If we really aren't measuring some of these things, that we really might get fooled. And so we embarked on a project. How can we actually begin to measure how we're performing, and then give the care team, and not just the providers, but the nurses, front desk, and everyone in the clinic ways to be able to improve. There's something called a Physician Excellence Project, practicingexcellence.com. You can take a look at it if you'd like. This is created by a physician who's a primary care provider in a sim in California. And they created a series, in this excellent website, but a series of videos that are short vignettes on things like how do you introduce yourself well to patients? What about the patient who is chronically late? What about a patient who is a drug seeker? What about opportunities for empathy and how to make sure you express that to patients? These types of things that we encouraged our care teams to do, and so they are actually having huddles early in the mornings. They spend about 5 to 10 minutes together. They view one of these videos, and they actually, more importantly, try to implement that suggestion for the day. And then the next time they meet, they talk about their successes. And so we've actually done this in over 8,000 patients now, but in this period anyway, 11 out of 15 categories, the patients who participated in this Practicing Excellence pilot had definitely higher scores. And these are just some examples. So this is timely answers to medical questions asked after hours. The participating physicians are in the light green and the dark green are their colleagues. So the score is basically the percentile, the national database percentile, and you can see that we increased from 26th to 65th percentile. Seen within 15 minutes, we improved there as well. I think a lot of that is just scripting and how you script that for patients. Clear communication from those providers was better. The program to listen to me, and the overall ranking of those providers was clearly better. So small changes make a big difference. So if it's something that you try to do every day, engaging those patients, what we noticed was that everybody's trying to get better, and so a very small incremental increase in your top box score when we took a look at that can mean a huge increase in your national percentile rate. making. Of course, that's what we're ranked on when we're looking at reimbursement. So that's a very quick overview of our efforts on behalf of the patient satisfaction. I would encourage you to feel free to give me a call at Avera if you'd like to explore any of these further. So I know that we're at the appointed hour, and so I'm going to stop there. And if there's any quick questions, I'd be happy to remain on the line.
Thank you, Dr. Jacobs. If anybody does have questions, and Dr. Jacobs, are you able to stay for a few minutes in case there's a question or two?
I am.
Okay. I believe the lines are open, so if you have a question, feel free to ask it. Doctor, what is the next step in your plan for continuing this coordinated care to have all of your providers participating?
So what we've found, and it was really a good opportunity to engage in this ACO, and because all of a sudden we had shared savings to share back with the clinics, right? And so one of the things that we're going to do there is identify where are those gaps in coordinated care, and each of these teams will reach a point where we'll need to add additional teams, and we've actually done that in one of our facilities. And so I think as this model shifts, and we're looking at it moving to a Track 3 ACO here next year, where we have a greater population that's involved, I think as dollars flow back to shared, I think part of that sharing definitely is expanding these coordinated care teams. Any questions? Feel free to reach out to me, everyone. Thank you very much.
Yep, thanks. And just to let everybody know, our next webinar in the provider perspective on patient-centered care is called Giving and Taking Control, and it's scheduled for July 11th at 12:15. You can also find additional information, tools, and resources for quality reporting and improvement at Great Plains Quality Innovation Network website, which is www.greatplainsquin.org. Thank everyone's time and participation. Please take a moment to complete the webinar evaluation upon exiting the system. Enjoy your day.